Yancey will be speaking on update on CHF, how to use ARNI and SGL2T inhibitors in practice. Dr. Yancey is Vice Dean of Diversity and Inclusion at Northwestern University Feinberg School of Medicine. He concomitantly serves as Chief of Cardiology at Northwestern University Feinberg School of Medicine and Associate Director of the Bloom Cardiovascular Institute at Northwestern Memorial Hospital. He holds the Magerstadt Endowed Professor of Medicine Chair and also holds an appointment as Professor of Medical Social Sciences. Dr. Yancey's research interests are heart failure, clinical guideline generation, outcome sciences, personalized medicine, and healthcare disparities. He is extensively published with well over 500 peer-reviewed publications and annual recognition as one of the most highly cited scientific authors worldwide. Dr. Yancey is Deputy Editor, JAMA Cardiology, and Senior Section Editor of Heart Failure, Journal of the American College of Cardiology. He serves on the editorial boards for Circulation, Circulation Heart Failure, the American Heart Journal, and the JACC Heart Failure. Dr. Yancey is a former president of the AHA in 2009 to 2010, and the recipient of the Gold Heart Award in 2014. In 2020, he received elected membership in the Association of American Physicians. He has many, many accolades and many awards, and he is probably the most articulate man I've ever met. And without further ado, Dr. Clyde Yancey, thank you for being here.
Thank you, Dr. Vogelman, and a really warm welcome to all of our friends and peers that are listening in on tonight's Illinois chapter of the ACC webinar. I'm delighted to know that this will be a series of conversations, and I really applaud the leadership for making special effort to be certain we all can stay up to date and engaged, despite the awkwardness of how we have to socially interact. I would support Dr. Vogelman's endorsement of our sponsors. Even the virtual formats require resources, and to have like-minded sponsors that support the actual discussion of up-to-date and relevant information is an incredibly valuable resource and something that we really cherish and appreciate. And so your opportunity to say thank you, to take a look at their site, idea. I'm going to pause for a minute and just give everyone an opportunity to go on mute. I'll wait just about 5 seconds. Please check your phones and be certain that you are on. Thank you very much. So we are going to talk about heart failure. In particular, we're going to talk about new therapies. I want you to look very carefully at the attribution for this graphic. It's in the Journal of the American College of Cardiology from 2013. 7 years ago, work that began in 2011, we came up with an updated algorithm in the treatment of heart failure. This algorithm that shows the 4 stages that are separated into those at risk for heart failure and risk of disease really was initiated in 2003. So it's been with us for 17 years, last updated in 2013, and many things have happened since then. But conceptually, it's still important for us to recognize that there is a progression of heart failure from those that simply have risk factors to those that have subclinical disease, to those that have symptomatic heart failure with either reduced or preserved ejection fraction. Most contemporary would also include mid-range ejection fraction, and then those that are in stage D, that is, despite being on appropriate medical therapy, are continuing to have symptoms. That's our template. That's how we started this conversation. Where we are now is in 2016 when we developed this treatment algorithm that was intended to go through the sequential steps necessary to make the correct decisions about treating heart failure. Step 1 is getting a picture, knowing that it's reduced ejection fraction heart failure. Then assessing the volume status and initiating guideline-directed therapy. You can see that that therapy consists of RAS inhibition, ACE, R, and ARB, not both together, and a guideline-directed beta blocker. Diuretics is needed for decongestion. That is a class recommendation 1. That's the stuff that's very much elementary. We must do these things. Graduate to step 2. There's 6 scenarios that we introduced 4 years ago. Go through this exercise because each of these scenarios will prompt another evidence-based therapy for heart failure That's in step 3. This allows us to develop a quasi-personalized approach to treating reduced ejection fraction heart failure, and only when symptoms persist do we get into the treatments for more advanced disease like transplantation, like LVADs. What's really important though is to understand that we have further enhanced this algorithm, and this was in 2017, by developing the Treat HF app. I've been advocating this all across the country. I'm doing it again tonight to my peers here in Illinois. This app can help you better process all of the different options and steps required to come up with the right combination of drugs and devices for your patient with reduced ejection fraction heart failure. This is available in the App Store or Google Play. If you haven't downloaded it, I would invite you to pause right now, open your phone, go to the App Store or Google Play, and download Treat HF. And again, I'll give you 5 to 10 seconds. In 2018, and I'm being very deliberate now with the chronology so you can see how things have evolved, there was this brilliant network meta-analysis put together by our colleagues in Europe. I know Mike Camaggio very well. This allows the comparison of outcomes across clinical trials to demonstrate what is the theoretical and optimal benefit of the best combination of agents. In so doing, they identified the following: the combination of an ACE inhibitor, evidence-based beta blocker, mineralocorticoid antagonist, and ivabradine, again a European exercise, showed a striking reduction in all-cause hospitalizations, 42% fewer hospitalizations for heart failure. That's real insight. It's a theoretical exercise, but that's real insight that the combination of evidence-based therapies can dramatically lower the morbidity of this condition. But what about the mortality? Look at the combination of the ARNI compound plus a beta blocker plus a mineralocorticoid antagonist. That odds ratio is 0.38, or a 62% reduction in the likelihood of death. My friends and colleagues, this again is a very compelling statement and would suggest that when we exercise the most exquisite use of available evidence-based therapies for heart failure, we can dramatically change the natural history. And that's why I have added the important footnote: guideline-directed medical therapy for heart failure works. What about in 2017, 2018? What were we thinking about within the American College of Cardiology? We put together our very first consensus pathway statement to talk about the pragmatics of how do you actually accomplish this. It is from this exercise that we developed the app that I've just shared with you, Treat HF. This came out online in December 2017. We published it in print January 2018. It was one of the most highly cited documents in the entirety of the JACC journals for 2018. But this is the takeaway. It deconstructed all of the evidence-based therapies and identified precisely how and when to use those therapies. The reference is placed here for your perusal. But then we got to a dilemma, and these data came forward the next year. This is from the CHAMP HF registry. Rarely does a registry become a landmark piece of information, but in this case it has. In patients that were evaluated in CHAMP HF, several thousand amassed from ordinary cardiology practices where the participants knew they were participating in a quality of heart failure care program, so they knew they were being evaluated. Look at what we identified. Only 1% of eligible patients were simultaneously treated with target doses of RAS inhibitor 1 of 3, ACE, ARB, or ARNI, evidence-based beta blocker, and MRA therapy, and only 25% received any dose of all 3 medicines. That was sobering, it was disheartening, and it made us understand how much work there is still to be done. And it really gave us the imprimatur to say we must think constantly about optimizing and then titrating GDMT. But look at all the reasons why you think this might not happen. You say, okay, well, we worry about blood pressure. Okay, fine. Well, let's just deconstruct this and look at those patients with the systolic blood pressure greater than 110. Even in those patients where the blood pressure is clearly greater than 100, you can see how few patients were treated with target doses of an ACE or an ARB, a target dose of an ARNI, even a target dose of a beta blocker, despite having an adequate blood pressure. The arrow really details the deficit, and I mean to use that word, though it's a harsh word, but the deficit in the quality of care. And these are contemporary data from 2018. You might say, okay, fine, that was a snapshot. Certainly, care changed over time. But pay attention to the 4 pie charts, one for ACE or ARB, one for the ARNI, one for the beta blocker, one for MRA. Red means that it was a medication that remained at a subtarget dose or it was never initiated. And the predominant color in each circle is red. Again, making the point that we can do a much better job of titration. And these data were published just last year. So contemporary information, not legacy stuff, but everyday medicine. We're failing to hit the mark of the titration medical therapy. Why does it matter? These are very impressive data published by Jim Januzzi and Jack. Looking at the ultimate change in NT-proBNP in response to heart failure treatment. What Dr. Januzzi's work demonstrates that whether we're looking at the aggregate of death or hospitalization or looking at hospitalization alone, in those patients where the NT-proBNP falls to less than 1,000 picograms per ml, that's where you see the probability of events lowest, either death and hospitalization or hospitalization. It's a very compelling graphic that makes the case that there is an association with better outcomes when we see this significant drop in NT-proBNP. This is even more compelling. You and I are practitioners. I still see patients in the hospital, inpatient, in my clinics. Someone comes in with a high NT-proBNP or a high BNP, and as a consequence of your medical treatment, they go from high to low. What does that infer from a prognostic standpoint? Well, look at heart failure, hospitalization, and death, and you see that high to low gives you a point estimate almost as good as low to low. What about all-cause death? Again, high to low gives you a very favorable point estimate. And when you put together the probability of the event and follow it out over time, it's very clear that if you take that patient with a high NT-proBNP and as a result of your therapy, that number plummets, you can feel comfortable that the probability of an event is less likely. This is very intriguing information. This is a log transformation of the NT-proBNP. So the lower the number is, or the negative number, in fact, means that the NT-proBNP is lower in the lowest. If you look at the left ventricular ejection fraction, left ventricular end diastolic volume index, B, left ventricular end systolic volume index, and C, left atrial volume index, and D, and look at Doppler parameters of diastolic function, and E, everything moves directionally in exactly the direction you wish as the NT-proBNP falls. It's not cause and effect. I don't mean to infer that, but there's a strong association that as we are able to optimize medical therapy, and coincident with that, we see this directional change in the biomarker that you can measure tomorrow in your office, in your hospital, in your practices, that gives you some confidence that you are going in a good direction for that patient. What about the newest therapy for heart failure with reduced ejection fraction? Again, I have the privilege of serving as deputy editor for JAMA Cardiology. Bob Barnow here at Northwestern in Chicago is the editor for JAMA Cardiology. And we see a wealth of information come across our desk as candidate manuscripts to be published. We were taken by this manuscript in 2017, which attempt to set the premise by which a brand new class of drugs ostensibly developed to treat diabetes and lower blood sugar actually might have cardiovascular benefits. I want you to pay careful attention to the areas that are targeted in this schematic. We're looking at myocardial energetics, left upper panel. We're looking at a reduction in preload and afterload as well as a drop in wall stress, left lower panel. At the kidney, we're looking at a recalibration of renal blood flow, one that reduces intraglomerular pressure, which we know to be adverse and cause glomerular hypertrophy. The end result is diuresis, natriuresis, glycosuria. So think about those benefits. I want you to see what really are the landmark data. This is from the EMPEROR trial, looking at empagliflozin. It was an inexplicable outcome that really shocked the community. A striking reduction on hospitalizations for heart failure that appeared to be much more significant than just simply play of chance. And in point of fact, when one aggregated all of the sodium glucose co-transporter 2 data that were present as of early 2019, this was published online in The Lancet in late 2018 by a good friend and colleague of mine, Mark Sabatine, but then came out in print in 2019, the EMPEROR trial using empagliflozin, the CANVAS program using canagliflozin, DECLARE trial using dapagliflozin. Look at these SGLT2 inhibitor studies. You see in the aggregate a point estimate that favors the prevention of heart failure, a reduction in the risk of heart failure events in those with type 2 diabetes. This was totally phenomenal because it was not what was expected, but it became pretty evident that there was something about the SGLT2 inhibitor class that was associated not only with lowering blood sugar, but with changing cardiovascular events. And in this case, new onset heart failure, incredibly important. And then we have these landmark data from just last summer. This is from the ESC meeting in 2019. This is DAPA-HF. And I want you to pay attention once again to the hospitalization data. Highly statistically significant information to suggest a benefit that was incredibly important. And you can see the primary outcome was highly statistically significant. What do all those charts and graphs mean? Well, the first thing they mean is that the benefit was seen across the board. What was different about DAPA-HF is that patients with and without diabetes were enrolled. And there was no difference in the benefit regardless of whether or not diabetes was present. So this was the next eureka moment. The first eureka moment was that these diabetes drugs reduced cardiovascular events. Remember, the context was many diabetes drugs exacerbated cardiovascular events. These reduced cardiovascular events. And the next eureka moment is that even in the absence of diabetes, the point estimate for a benefit on serious heart failure events was still favorable, which really told us that there is something independent of blood sugar lowering that is helping the cardiovascular profile. Here are the takeaway points from DAPA-HF. First, the benefit is seen in those with without diabetes. Next, it's once a day therapy. There is no need for titration. There are no episodes of hypoglycemia and diabetic ketoacidosis reported in DAPA-HF. And there was a negligible incidence of amputations. The number needed to treat, something we follow sometimes preferentially over a p-value, was just 21. Profoundly important metric. And even in those patients greater than 75, striking benefits were seen. This summer, we will see EMPEROR reduced. If we see the EMPEROR reduced looking at empagliflozin and validate these same findings, that will clearly establish a new direction that we need to go. But we still are searching for a mechanism of action. Maybe that mechanism of action is here in the heart-kidney interface. We know that heart failure in large measure depends on the intact kidney, and kidney failure in large measure must depend on having intact cardiovascular physiology. The two are so closely intertwined. And when the physiology in one is perturbed, the physiology in the second is perturbed as well. You can see there are a variety of shared hemodynamic mechanisms, there are a variety of shared neurohormonal mechanisms, and a variety of very sophisticated activities like inflammation, cachexia, fibrosis, acid-base disorders that affect both organs. But what about the class effect of SGLT2 inhibitors, not on the heart now, but on the kidney? And this is what really tells us. If you look at credence, look at CANVAS, canagliflozin, EMPEROR, empagliflozin, DECLARE, dapagliflozin, what you see consistently is that the SGLT2 inhibitor reduces the composite of renal outcomes. So let's all just pause for a minute. This really is something to sit back, and if you've been in medicine for some period of time, this really is a gotcha moment, because this one class of drugs lowers blood sugar, helps facilitate treatment of diabetes. This one class of drugs reduces de novo onset of heart failure in the diabetic patient and improves heart failure outcomes regardless of whether or not the patient has diabetes. And the same class of drugs improves composite renal outcomes, particularly in diabetic patients, including progression to end-stage renal disease. These are important observations that will go forward in our day-to-day practice as we consider the benefit of this new class of therapies. So what are the favorable effects? They're on the left side of the screen. The unfavorable effects are few. Amputations were seen early on, distal amputations. This may be a phenomenon of volume contraction. Hypotension does occur, volume depletion does occur. Urinary and genital infections because of glucosuria. Bone fractures may occur infrequently. Diabetic ketoacidosis, nearly rare, but that is counterbalanced by the wealth of favorable effects you see here. That gets us to an important statement made by Eugene Brunwald, and I completely endorse the idea that we have seen a victory in our struggles against heart failure. We've seen the development of a variety of programs, several different drugs that have helped us understand how the intersection of diabetes and cardiovascular disease leads to heart failure prevention. And now, even in the absence of diabetes, these same drugs that prevent heart failure help to treat heart failure. And I fully concur that there is now a fifth foundational pillar in the treatment of heart failure with reduced ejection fraction. The RNA compound, number 1, the ACE or the ARB, number 2, the MRA, number 3, beta blocker, number 4, and the SGLT2 inhibitor, number 5. And I think this is important take-home information. Now, let me close by taking you through the thought experiment. These data were published just 2 months ago. The idea is, what happens if you look at the outcomes that I mentioned earlier on in the Mike Comanche network meta-analysis? The ACE or the ARB plus the evidence-based beta blocker as conventional therapy, and then take comprehensive therapy, substituting the ACE or the ARB for the RNA compound, adding the MRA, and adding the SGLT2. I want you to look at event-free survivals here. The difference between comprehensive and conventional. Again, we're looking at a composite of death or hospitalization and death alone. And we see something very interesting that compared to the conventional therapy, the comprehensive therapy gives you between 6 to 8 additional years of event-free survival. This is a striking analysis. What about taking this a step further and thinking about, in those patients who are able to take these drugs, what is the longevity you might expect? We're thinking about projected mean overall survivals of up to 18 years with comprehensive therapy. That is a compelling observation, and the narrative makes it very clear. If you look at the additional years of event-free survival for an 80-year-old, even for an 80-year-old, up to 3 additional years, and for a 55-year-old, up to 8.3 additional years free from cardiovascular death or first hospital admission for heart failure. I think these are very important observations. Again, it's a theoretical model, but it's a model based on evidence-based therapy, randomized controlled trials. It sends a very important message that there's an opportunity to further improve outcomes in heart failure by graduating our therapies to these more comprehensive disease-modifying therapies. Dr. Fonero and I have been working together for literally 15 years, and we have jointly replicated this exercise over and over again. We've done so every time there was a new therapy that had a benefit. If you start at the top, where there are no evidence-based therapies, and it's just digoxin and diuretics, if you will, the 2-year mortality is 35%. That's cut in half with the ACE or ARB, cut again with the beta blocker, cut again with the aldosterone antagonist, cut again replacing the ACE or ARB with RNA, then adding the SGLT2 inhibitor. The number needed to treat with this absolute risk reduction, 26%, is only 4. It's only 4. You think about what we hear about from the COAP trial about doing an edge-to-edge closure of the mitral valve, and the number needed to treat is 5. This is even better. Just the optimal, careful use of evidence-based therapy provides so much benefit here. So let me close by taking you through a case to try to put some of this into perspective. 78-year-old man presents to the emergency room 2 days of progressive shortness of breath with apnea and PMD. He's dyspneic at rest because of his family history. He's quite concerned that he may have heart disease. Hypertension, dyslipidemia, and myocardial infarction 4 years ago. Daughter has hypertension, wife is on heart failure. It's on aspirin, a statin, torplosuccinate, prazosin, and has a remote history of smoking. You do your physical exam from afar because of today's environment, so you conduct a telemedicine visit that's enabled with video. His blood pressure is 116/82. His heart rate is 96. That comes from a smartwatch. He has dyspnea while he's speaking to you in short sentences. Using the video, you can see he has prominent neck veins. He tells you that he feels a rustling sensation in his chest, and when you take the video and train it to his legs, you see obvious peripheral edema. You strongly suspect new onset heart failure. His etiology was dyspnea. You instruct him to present to the ED, and you order an ECG, chest X-ray, and some relevant labs. The NT-proBNP returns at 3,000 picograms per ml. His prognosis is poor. That's A. B, he clearly has increased ventricular diastolic pressures. C, both. D. So I'm looking for the chat function to see if I can see responses. So first of all, we can't yet say his prognosis is poor because I've shown you that with therapy, we can see a reduction in the NT-proBNP, and in so doing, particularly if it drops below the critical threshold of 1,000 picograms per ml, his prognosis might indeed be better. Does he have increased ventricular diastolic pressures? Well, almost assuredly at an NT-proBNP of 3,000, we can feel confident that that's the case. And when we look at his chest X-ray, as you see next, that is confirmed. So for certain, he has congestion, increase in diastolic pressures, pulmonary congestion. That explains his symptoms. Now you order furosemide, 80 milligrams intravenously. Patient feels better almost immediately. What is your next step? A, initiate evidence-based beta blockers. B, start the ARNI compound. C, initiate ivabradine because it does have a resting heart rate of 96. D, increase the dose of the loop diuretic. E is all of the above. F is none of the above. I'll let you think this through. Give you a few minutes, not a few minutes, a few seconds. Then I'll go through each answer for you. So this is still within the first 24 hours. He still has decompensated heart failure. This is not the time to initiate the evidence-based beta blocker. You wouldn't start the ARNI compound because the guidelines still suggest that the first step is an ACE RNA-ARB. And even though the heart rate is elevated, ivabradine is not indicated until you've used the beta blocker and the heart rate persists despite being on a reasonable dose beta blocker. So the critical discrimination is, do you increase the dose of loop diuretic or do you continue it as it is? If you continue it as it is, the answer would be none of the above. If you increase the dose of loop diuretic, it would be D. And I'll give you a chance to think about this. So the answer is none of the above. You've given him a dose of a loop diuretic to which he feels better and he's had a good diuresis. There's no reason to increase that dose further, rather to give that dose on repeated measures, that is at 8 hours or 12 hours. So let's keep this exercise going. So you do that. You don't increase the dose. On the second hospital day, he feels substantially better. His congestion has improved. His NT-proBNP is now less than 1,400, but the creatinine has increased from 1.8 to 2.2 milligrams per deciliter. You will get this phone call from your nurses, from your physician assistants, from your nurse practitioners. If you work with interns and residents, you will get this phone call probably this week. So here's a question. This is consistent with an acute kidney injury and portends a worrisome prognosis and is a challenge to optimal guideline-directed medical therapy for heart failure with reduced ejection fraction. Is that statement true or false? acute kidney injury, worrisome prognosis, and a challenge to optimal GDMT for reduced ejection fraction heart failure. So if you said that was true, let me share this with you. This was published just a few months ago. Incredibly important. For certain, there's been a change in his estimated GFR. We respect that because we've always worried that a delta change in serum creatinine of just 0.2 milligrams per deciliter, certainly 0.3 or greater, is sufficient to make us become very concerned about adverse outcomes. However, these data really give us great clarity. When there is a concomitant decline in the BNP or an increase in hematocrit, you can see that everything is different. The hazard ratio for death is reduced when there's an increase in hematocrit or decline in BNP, even with the decline in estimated GFR, where at face value, the hazard ratio for death is slightly increased. If you look at the lower panel on the work by McCollum and colleagues, what you see is that with the greatest decline in estimated GFR, but also greatest decline in BNP, you're at least at neutrality and even better than neutrality on the hazard ratio for death. And with the greatest increase in hematocrit, despite the decline in GFR, the same thing is observed. This is a clinical pro you can use this week. If you're diuresing the patient, the creatinine goes up. I'm concerned like you are. But coincident with that, the hematocrit has gone up, and the BNP is falling. The likelihood that you've caused a substantial injury that will lead to worse prognosis is low. You need to be judicious with continued diuretic administration, but don't think you've overshot, and don't put this in a bucket that goes with a poor prognosis. So let's wrap this up. He remains in hospital, diuresing well on regimen, furosemide 80 IV twice daily, echocardiogram is complete, reduced ejection fraction heart failure is confirmed at 30%. What will you do now? Topical succinate, lisinopril, spironolactone, the ARNI, A, B, and C, that is beta blocker, the ACE and the ARNI, and the MRA, or F would be D only, the ARNI compound. So would you give beta blocker, the ACE, MRA, or would you give one of those, or would you just go to the ARNI? And I'll give you a chance to think that through. So the answer is E. You would go with the beta blocker, the ACE, and the mineralocorticoid receptor antagonist, particularly if the estimated GFR is greater than 30 cc's per minute. Now he's stable on the ACE, beta blocker, and MRA. He's an outpatient and is seeing you in your office. What would you do for his HFrEF therapy? He's feeling well, no need to change. Or would you advance each drug you've already started, attempting to achieve doses in clinical trial? Would you start with a beta blocker and then uptitrate the other therapies? Would you advance diuretics to be certain the patient's euvolemia, particularly if it's a high cell diet at home? Would you switch to the ARNI compound and uptitrate the ARNI compound and then add the SGLT2 inhibitor? A, B, C, D, and E. So hopefully you selected E because it's appropriately indicated to switch to the ARNI compound, and particularly if Emperor reduces positive, to add the SGLT2 inhibitor. You can see the resolution of the case. You can see some concerns about polypharmacy and cost. We can talk about that in our discussion. Cardiac rehab is always appropriate. Repeat ejection fraction measurements uniformly demonstrate that the LVF will respond to the appropriate doses of evidence-based therapy. Patient feels better, has more exercise capacity, the symptoms of congestion are fully resolved. Thank you very much for your time and attention. We've stayed within our time frame and happy to yield to the next speaker.
Thank you so much, Clyde, or Dr. Yancey, as you corrected me. So,
That was an inside stroke. Don't do that.
Dr. Yancey, Dr. Casey asked this question earlier. Can you please discuss the guide IT from JAMA Cardiology earlier this year? Do you believe that optimal GDMT goals are unrealistic? If not, I hope. What do we do as a healthcare system, not as an individual practitioner, need to be doing differently?
So, very good question. And Don may have realized that just within the last 2 weeks, we published yet another a manuscript from Guy Jeff that demonstrated the inability to achieve these doses for reasons that still have to be further explored. So I agree, there is either a hesitancy, an awkwardness, or complexity that goes along with getting to the higher doses of guideline-directed medical therapy. So much so, Don, that what may be happening is a predictor of best outcomes for heart failure would in fact be the ability to tolerate higher doses and a complex medical regimen. We may be looking at this the wrong way. We may be thinking that the physicians are failing to do the titration, but the inability for the patient to be able to be exposed to the higher medicines, to execute it, even if it's a non-physiologic reason, polypharmacy, cost, access to care, etc., that may be something that we need to consider. What encourages me, though, is increasingly there are data that professionals like Vic Cruz on the leadership group with us tonight are able to take these patients and select patient management programs and truly achieve optimal doses of medical therapy. Maybe that's the way we need to do this going forward.
I have one question. A lot of my patients will not get their insurance to pay for some of these medications, such as the ARNI, and we need pre-authorization. We need help usually to get those pre-authorization, and also Vabradine is very expensive. Are organizations trying to do something about the prices of all these medications?
So very good question, and really a shout out to the ACC for developing a database on the experience of PA, prior authorization, with a very committed initiative to bring the aggregate experiences collated from across the country to the attention of healthcare regulators, including CMS, because it's pretty evident that the pharmacy benefit managers have exerted exquisite power in the access to medical therapies, particularly those that are more costly. And so this is an ongoing struggle that we need to address. Nevertheless, in my own practice, it's been quite some time for us to be unable to get the ARNI compound to patients. We really have experienced a greater flow, a greater access to this. Part of it is familiarity, part of it is the evidence has come forward about cost effectiveness. So that has been encouraging. It's a new struggle. I've just begun to prescribe SGLT2 inhibitors. That is a brand new struggle. And many times I'm having to engage with the primary care physician, the internist, and maybe that's the right way to do this. And we're working collaboratively to try to secure these therapies for patients with predominantly a cardiovascular indication. By the way, dapagliflozin does have an FDA label approval for heart failure, so it's not off-label therapy, but it is admittedly a challenge. And certainly if we talked about the PCSK9 inhibitors, that's even a different discussion. So granted, there are some challenges there, Dr. Vogelman, but they can be navigated.
And speaking of the new SGL2 inhibitors, we're going to the next talk, but I do question whether we're the ones who should, as cardiologists, be initiating these new medications. I think we're still depending on our endocrinology colleagues to initiate those drugs, but I think we're going to need to learn how to use them ourselves.
You know, one of the reasons why I really wanted to be deliberate and review the experience from DAPA-HF is qualified by the fact that these are mild to moderate heart failure patients, not advanced patients. But the point here is that it's a single dose, regardless of age, sex or gender, body weight, race, 10 milligrams a day, no titration, no episodes of hypoglycemia, no episodes of diabetic ketoacidosis, negligible episodes of distal amputation. Granted, in clinical practice, so many different things can happen. And certainly if it's a complicated diabetic patient, that's when I really want to have the endocrinologist involved. But for the purposes of treating heart failure, I'm comfortable describing a once-a-day therapy with a minimal side effect profile and trusting my nurse team to help manage the circumstances. So I think that in the heart failure space, we can go forward predominantly as a prescriber of record. For the diabetic patient, I always partner with the team because there's so many other permutations of guideline-directed diabetes care that really I should not attempt to manage.
So just to summarize, so for non-diabetics, you would just initiate empagliflozin 10 milligrams once a day without consulting.
The pagliflozin is what we have an indication for.
Right. So without consulting with the endocrinologist, you would just
Correct.
start that on your own, 10
It's
milligrams
treatment
once a
for
day.
heart failure. Correct.
Okay. Thank you so much.
Okay.
So that really helps me. I really have been wanting to do this, but I'm very reluctant because I feel like I don't know how to use those medications well. And actually, this is a great segue to our next speaker, whom Dr. Vicki Grew will introduce. Thank you so much, Dr. Yancey, for that incredible talk, and you've taught me once again. Thank you.
So thanks, Dr. Yancey. Gave a pretty convincing talk for using SGLT2 inhibitors in our heart failure patient population. And with that, Liz is going to teach us a little bit more about not just SGLT2 inhibitors, but GLP-1 agonists. And as a pharmacist who trained years before any of these medications were available, and a pharmacist who works in cardiology, I feel it's important for us to expand our knowledge in these medications. So Liz is a clinical assistant professor of pharmacy practice at the University of Illinois at Chicago College of Pharmacy and a clinical pharmacist for UI Health's internal medicine clinic. She received her Doctor of Pharmacy degree from Midwestern University College of Pharmacy and then completed a PGY1 and PGY2 residency at the same location. She currently works alongside attending physicians, medical residents, and advanced practice nurses at UI Health to optimize chronic disease management for a variety of conditions, including diabetes, hypertension, and cardiovascular disease. Liz is also responsible for implementing quality improvement initiatives for the institution's managed care population, and she is an active member of a variety of organizations, including the American College of Cardiology.
These new anti-hyperglycemic medications for cardiovascular disease and their considerations for use in clinical practice. I'm hearing there's a little bit of a need for it based on previous comments, so I'm so happy to be here today. These are my learning objectives for your review, as well as abbreviations, a list of abbreviations for your reference throughout the presentation. So I wanted to start today's discussion with two clinical cases that may represent patients that you see in clinical practice that may benefit from these therapies. The first is a 69-year-old woman presenting for chronic disease management. She has a medical history significant for type 2 diabetes, hypertension, obesity, and a myocardial infarction 1 year ago. Her current medications include saxagliptin, 2.5 milligrams, metoprolol succinate, lisinopril, atorvastatin, as well as aspirin. And her most recent A1C from 2 weeks ago was 9.4%. All of her labs are within normal limits except for her serum creatinine, which is 1.6, and her eGFR, which is 33. So I'll go ahead and let you think about that patient really quick, and we'll review the second case. And the second case is a 75-year-old African-American man. He has a past medical history of hypertension, heart failure, reduced ejection fraction, and type 2 diabetes, as well as peripheral vascular disease. His most recent labs include a serum creatinine of 1.5 milligrams per deciliter, an eGFR of 52, and an A1C of 7.8. His current medications include guideline-directed medical therapy for heart failure, reduced ejection fraction, atorvastatin, as well as aspirin. And then for his diabetes, he's taking metformin 1,000 milligrams twice daily, glyburide, as well as linagliptin. So I'll let you go ahead and think about these cases throughout the presentation, and towards the end of the presentation, we'll go ahead and review the best option for these patients. So as you know, cardiovascular disease is still the leading cause of morbidity and mortality in patients with diabetes. It's estimated to cost, diabetes-related cardiovascular-related care is estimated to cost the U.S. approximately $37 billion per year. And more recently, heart failure is gaining traction and being recognized as a complication of diabetes, with patients being at increased risk, 2 to 4 times increased risk to developing heart failure compared to those without diabetes. Additionally, for each 1% increase in A1C, this risk increases by 8%. And this statistic becomes increasingly important for cardiologists since recent data suggested that cardiologists see patients with diabetes and cardiovascular disease 5 times as often as those patients see endocrinologists. So knowing how to start these medications and use them in your patients is going to be key to reducing your cardiovascular risk and improving those clinical outcomes. So just to review, the general A1C goal for most patients per the American Diabetes Association guidelines is less than 7%. However, a less stringent goal of less than 7.5 to less than 8.5% may be appropriate for patients that have a lower life or limited life expectancy, advanced complications such as cardiovascular disease that may be representative of patients you see in clinical practice. For patients that we set an A1C goal of less than 7, just a reminder that we usually set a fasting blood sugar goal of 80 to 130 in those patients and a postprandial blood sugar goal of less than 180. However, if you're going to go ahead and adjust those A1C goals to a more lenient goal, this table kind of provides some guidance on how to adjust those daily blood sugar targets so that patients can more accurately and effectively engage in their self-monitoring program as well as their entire care. So before we get started on the clinical considerations for use, I know Dr. Yancey just covered the cardiovascular outcomes trials for the SGLT2 inhibitors, but I'm going to briefly review this data and how they have shaped the updates in the ADA guidelines. So this is just a review of all the published cardiovascular outcomes trials to date. And we'll start our conversation with the DPP4 or dipeptidyl peptidase 4 inhibitor trials. So these were some of the first cardiovascular outcomes trials published. Just a reminder, those trials were initially designed to demonstrate cardiovascular safety through a non-inferiority design. So here we have the SAVOR-TIMI trial that demonstrated actually an increased risk of heart failure hospitalization, which was a little bit unexpected. Of note, they all demonstrated cardiovascular safety and therefore are considered safe in cardiovascular disease. However, what they weren't expecting to find was this increase in heart failure hospitalization with the use of saxagliptin. The TICOS trial and the Carmelina trial subsequently were published and demonstrated that sitagliptin and linagliptin, respectively, were safe with regard to heart failure outcomes, but it was initially unknown whether alogliptin had any impact on heart failure hospitalization. Therefore, investigators did perform a post hoc analysis that demonstrated alogliptin was associated with an increased risk of heart failure hospitalization, specifically in patients that had no history of heart failure at baseline. And this really led to the 2016 FDA safety warning that warned for the risk of heart failure in patients using saxagliptin and alogliptin if they had heart disease or kidney disease at baseline. And that was really based on those that Examine and the SAVOR-TIMI trials. As you may know, actually to back up for a second, the glucagon-like peptide 1 receptor agonists, I've organized the cardiovascular outcome trials by those that are short-acting agents as well as the long-acting agents, which are on the next slide. As you may know, the LEADER trial was one of the first cardiovascular outcomes trials to show cardiovascular benefit with a GLP-1 agent. Liraglutide did decrease that 3-point major adverse cardiovascular endpoint, which was a combination of cardiovascular death, non-fatal MI, and non-fatal stroke. And that was really driven by a reduction in cardiovascular death. More recently, Pioneer 6 examined the role of semaglutide and found that while it didn't decrease that risk of that MACE endpoint, it did reduce cardiovascular death alone. And you'll notice that lixisenatide did demonstrate cardiovascular safety. However, it did not significantly reduce that MACE endpoint, so no cardiovascular benefit. For the long-acting agents, you can see that several of them do provide cardiovascular benefit. Specifically, semaglutide, albiglutide, and dulaglutide all provide a reduction in that 3-point MACE composite endpoint. And that was either driven by a reduction in non-fatal stroke or myocardial infarction. Exenatide extended release did not show that benefit in cardiovascular risk reduction. It just narrowly missed that confidence interval that lied on the upper bound laid on 1. So that one does not demonstrate cardiovascular benefit. Of note, something that was unique about the REWIND trial was it did include a majority of patients that did not have cardiovascular disease at baseline. So it really showed that dulaglutide could be considered in patients for primary prevention purposes, and that was the first that we saw of this in the cardiovascular outcomes trials. You'll notice that none of the GLP-1 receptor agonists have any impact on heart failure hospitalization. And then we had the SGLT2 inhibitor cardiovascular outcome trials, which Dr. Yancey was kind enough to review for us as well. But the differences between some of the agents as well as the baseline populations may have generated some differences with regard to the results of these trials. Specifically, we saw that empagliflozin did decrease that 3-point MACE outcome in the EMPA-REG trial, and that was really driven by a reduction in cardiovascular death. What was unexpected was that 35% reduction in heart failure hospitalization. And then the CANVAS program was published, and it demonstrated a significant reduction in that MACE endpoint. However, none of its individual components of that composite endpoint was significant alone. It too showed a reduction in that heart failure hospitalization. And then the DECLARE TIMI trial was published, looking at the role, the safety of dapagliflozin, and that trial did not meet that statistically significant difference in, or statistically significant reduction in the 3-point MACE. However, the added co-primary endpoint of cardiovascular death and heart failure hospitalization was shown to be significantly reduced. And that was really driven by a reduction in the heart failure hospitalization. So it continued with our trend with this benefit for heart failure hospitalization, as CV death alone was not significant in that trial. So there was a hypothesis that these different reductions in MACE endpoint or different impact in MACE endpoint was due to the differences in patient severity at baseline. However, actually just last month, the results of the VERTA-CV trial were published, and that looked at the safety of ertugliflozin in patients with 100% of patients having established cardiovascular disease at baseline. And what they found that it did not have an impact on that 3-point MACE outcome. However, it did reduce heart failure hospitalizations, confirming that this is a class effect. So based on this information, the ADA guidelines now recommend adding one of these agents in patients that have a high CV risk, established cardiovascular disease, heart failure, or CKD, and that's independent of or irrespective of baseline A1C or individualized A1C target. Specifically, if atherosclerotic cardiovascular disease predominates, or so patients have established ASCVD, or they have indicators of high cardiovascular risk, they do recommend a GLP-1 receptor agonist that has that proven cardiovascular benefit. So those are listed there for you along with their respective trials. And then the SGLT2 inhibitors are recommended on an equivalent level with those GLP-1 receptor agonists. And the guidelines do rank that empagliflozin is a little bit more preferred compared to canagliflozin, and that's really just between or based on the reduction in cardiovascular death seen in the EMPA-REG trial versus a reduction in the composite MACE endpoint seen in the CANVAS program. For patients in which CKD predominates or heart failure predominate, specifically heart failure reduced ejection fraction or chronic kidney disease with macroalbuminuria, they do recommend a SGLT2 inhibitor first to go ahead and reduce those clinical outcomes, as they were pretty consistently seen to benefit those outcomes in the cardiovascular outcomes trials. And if an SGLT2 inhibitor is not tolerated or they're contraindicated, they do recommend adding a GLP-1 receptor agonist that has that proven CV benefit. So since these medications are now recommended irrespective of baseline A1C or individualized A1C targets for patients with these comorbidities after metformin, it's going to be really important to understand how they work and how to integrate them in clinical practice, since patients are going to be indicated for these medications. So I just kind of like to introduce GLP-1 agonists to my patients by explaining how they work. It tends to help them adjust to those adverse effects and know how to manage them. So these work by mimicking this endogenous GLP-1 that's within our bodies. They cause glucose-dependent insulin secretion, as well as decrease hepatic gluconeogenesis. They slow gastric emptying rate and therefore promote satiety and facilitate weight loss by reduced food intake. Trials demonstrate an efficacy of 0.5 to 1.8%. However, in clinical practice, I've seen A1C decreases up to 5% for patients that are well above goal and respond really well to these medications. The doses and titration schedules of the short-acting agents, again, I've broken them down by short-acting agents and long-acting agents, are listed here for you. A couple nuances between some of the short-acting agents. Both exenatide and lixazenatide do have to be taken within 60 minutes prior to meals. They both also have a renal threshold for use, so something to consider in your patients with CKD. Oral semaglutide is one of the newer GLP-1s available. However, it does have some extensive administration requirements. Specifically, the manufacturer recommends that these be taken in the fasting state at least 30 minutes prior to food, other beverages, and other oral medications, and no more than 4 ounces of water. And they really recommend as small of a sip of water as possible. And that's due to the risk of deactivating that absorption enhancer and therefore limiting the absorption of this medication. So it cannot be taken with too much water, otherwise the medication won't work. Of note, all of your short-acting agents that are injectable do require a separate order for pen needles, and I always recommend 4 or 5 millimeter pen needles just to prevent the risk for an IM injection. And then your GLP-1 or long-acting GLP-1 agonists are listed here for you. Typically, if there is another or a higher dose, you can up-titrate after 4 weeks once that initial dose reaches steady state. They can all be taken without regard to meals, so any time of day, it doesn't matter. Exenatide extended release is one of the only agents one of the only long-acting agents that has a renal threshold for use. And what's nice about these medications is that they do offer a pretty flexible misdosing window. So for your more forgetful patients, as long as they remember within 4 or 5 days of their scheduled dose, they can actually stay on their regular scheduled dose without the risk of that medication stacking in the bloodstream. All of the long-acting agents either come with their own supply of pen needles or are self or auto-injectors where you don't have to prescribe pen needles at all. So no need for an extra order for pen needles with these medications. So I really like these medications for clinical practice. When used alone or with other medications that have a low risk for hypoglycemia, there's very limited risk. However, when used with insulin or secretagogues, such as sulfonylureas or meglitinides, there is a slight increased risk for hypoglycemia. So typically, if patients are closer to their goal, we'll go ahead and reduce that insulin dose by 10 to 20% when starting a GLP-1 receptor agonist. If they're on glipizide 10 milligrams twice a day and they're closer to their goal, we may back off the sulfonylurea dose, maybe to 5 milligrams twice a day when starting these medications. However, if the patient is well above their A1C goal, we don't back off any of the medications and go ahead and add them on and just bring them back for a closer follow-up, preferably when they're due for a dose up titration. These medications also cause modest weight loss. In clinical trials, it's been documented at 6 to 5 kilograms of weight loss. However, in clinical practice, I've seen 40 to 50 pounds of weight loss in patients that have a higher BMI at baseline. One thing to note is that if you are using these in patients with heart failure and they have weight loss, it may mask their volume status. So it's important to go ahead and continuously reassess for a baseline dry weight if those patients lose significant amounts of weight. Additionally, these medications cause early satiety. So being able to distinguish, is that early satiety due to the GLP-1 agonist because of its delayed gastric emptying, or is it due to fluid accumulation around the abdomen from worsening heart failure, and having patients be able to identify different signs and symptoms of volume overload. In terms of disadvantages for these agents, most of them are injectable, and unfortunately, their pen devices do vary pretty significantly from insulin pen devices. So even if a patient is familiar with an insulin injectable, they do vary significantly from those devices. So it is important to go ahead and counsel those patients on the use of these medications and specifically the injection technique before they leave the office. Additionally, oral semaglutide provided a nice option for patients that declined injectables. However, it does have pretty extensive administration requirements, and it can be even more cumbersome when patients are on other medications that require spacing from food and water or other beverages, such as thyroid hormone replacements or bisphosphonates. You may well know that the most common side effect with these medications are those GI adverse effects. So specifically nausea and often vomiting are things that we do see in clinical practice. However, I find that appropriate counseling and coaching patients through starting the medications is really key in helping them tolerate these medicines. So I always encourage patients to have smaller, more frequent meals when starting these medications, eat more slowly, determine if they're full to avoid overeating, and it kind of helps them manage that delayed gastric emptying rate. Additionally, these GI adverse effects are usually transient and resolve within a week. So kind of letting them know this information is often giving them the light at the end of the tunnel. And of course, if they're continuing to have GI adverse effects and they still want to stick with the medication, you can always extend that dose titration period. These medications should be used in caution with patients that have a history or are at risk for pancreatitis. And of course, due to that slowed gastric emptying rate, they should be used in caution with patients with a history of gastroparesis. Absolute contraindications for these medications are listed there for you. So the SGLT2 inhibitors, they block glucose reabsorption in the proximal tubule, and that promotes glucosuria and therefore a reduction in blood glucose levels. A1C efficacy is 0.5 to 1% in trials. However, in clinical practice, similar to the GLP-1 receptor agonists, it all depends on their A1C at baseline. I've seen A1C reductions up to 3% in patients that were maybe not adherent to their other medications previously, or just responded really well to these medications. Individual agents are listed here for you, as well as their titration schedules. Most are up titrated after 30 days to their next dose if further blood glucose lowering is required. Of note, canagliflozin is the only one that has to be taken with regard to meals, should be taken before the first meal of the day. Others can be taken with or without food. However, due to its osmotic diuretic effect, I always encourage patients to take them in the morning, and that way you can kind of limit nocturia for your patients. It's just kind of being kind. All of these medications have an eGFR cutoff for use. However, these were originally based on the fact that these medications were not effective at A1C lowering at later stages of kidney disease, specifically stage 3B CKD. However, they're not harmful at lower eGFR levels. In fact, more recently, as we learned in the DAPA-HF trial, dapagliflozin was started as long as patients' eGFR was above 30 and at the 10 milligram daily dose. Additionally, canagliflozin was recently studied in the Credence trial, and they found that even in patients with stage 3B CKD, as long as patients had macroalbuminuria, canagliflozin could be started and continued per their protocol down into dialysis or transplantation. And this really still improved kidney outcomes in this patient population, demonstrating the clinical benefits of using these medications in later stages of CKD. Advantages of these SGLT2 inhibitors, again, similar to the GLP-1 receptor agonists, they have a low risk of hypoglycemia when used alone or with other medications that have a low risk. However, that risk is increased when used with insulin or secretagogues. Similar to the GLP-1s, if we are starting these medications in patients that are closer to their goal, I may back off the sulfonylurea by 50%. However, with starting these SGLT2 inhibitors in the presence of insulin, we generally have a more conservative reduction in that insulin dose, just because we know that abrupt discontinuation or significant dose decreases of insulin in the setting of SGLT2 inhibitors has been associated with euglycemic ketoacidosis. So we usually have a more conservative 10% reduction in insulin doses when starting these medications, specifically in patients that are closer to their goal. Of course, if patients aren't close to their goal, you can just add them on and go ahead and bring them back in a month or so to reevaluate. As Dr. Yancey mentioned, these also have benefit in terms of weight loss, blood pressure, and serum uric acid levels. In terms of disadvantages, these medications are most well known for their risk for genitourinary infections in patients with type 2 diabetes. This risk is increased generally in patients with a history of UTI or mycotic infections, as well as uncircumcised males. I always promote the importance of proper hygiene when starting these medications. In terms of bone mineral density, canagliflozin has been shown to reduce that in clinical trials, as well as increase the risk of foot amputations. And that was really seen in the CANVAS program. They found a 20-fold increase in the risk of amputations in patients that had a history of amputations or peripheral vascular disease at baseline. So we know that those are risk factors for this unfortunate adverse effect. So perhaps avoiding it in those patient populations. Additionally, herniated gangrene was recently identified as an adverse effect. We do know that herniated gangrene is associated with uncontrolled diabetes to begin with, and this was really only identified in 55 case reports. So the low risk of this complication really doesn't warrant withholding these medications from patients that could benefit from them clinically. Other disadvantages, these do have an osmotic diuretic effect, so that can lead to hypovolemia and orthostatic hypotension. And we do know that it reduces the loop diuretic dose that's needed from the DAPA-HF trial. So you can often consider a reduction in diuretic dose if patients are on the euvolemic side, or if they're on the hypervolemic side, going ahead and adding these medications on and then bringing them back in for a follow-up sooner rather than later. Because of the osmotic diuretic effect and the polyuria, patients often also experience increase in thirst and dry mouth. Acute kidney injury is an identified adverse effect, so I usually monitor the BMP at baseline and periodically thereafter, usually about 2 to 4 weeks, similar to what you would maybe do with starting a RAS inhibitor. In general, in practice, I've seen acute kidney injury kind of precipitate when these medications are started or increased in the presence of a RAS inhibitor or a diuretic being started or increased at the same time. So I do recommend making only one change in a medication that could have hemodynamic effects on the kidney at one time. And then euglycemic ketoacidosis was one of those rare adverse effects from these medications, mostly identified in patients with type 1 diabetes. However, there have been reports of this complication in type 2 diabetes patients. Again, abrupt discontinuation or dose decreases of insulin can precipitate euglycemic ketoacidosis. Other risk factors include febrile illnesses, surgery, ketogenic diets, and prolonged fasting states. One thing to note about the presentation of UDKA is that hyperglycemia is often missed or not present, which leads to this side effect often being missed in emergency departments. So they often present with a blood sugar less than 250 milligrams per deciliter. Additionally, these medications cause excretion of urinary ketones at baseline. So it's really important to go ahead and measure the blood ketones to be able to distinguish the presence of UDKA. To mitigate this risk, I do recommend educating your patients on the signs and symptoms of UDKA, avoiding off-label use in type 1 diabetes, and there are new recommendations for holding these agents prior to surgery or prior to scheduled surgery, and those are listed there for you. So we're back to our clinical case. It's our 69-year-old female. I'll give you a few seconds to go ahead and read through her case again and then consider the best options. All right, so this patient had a myocardial infarction 1 year ago. She's 69, and she's on saxagliptin 2.5 milligrams daily currently as her only therapy for type 2 diabetes. So we do know that from the cardiovascular outcomes trials that the DPP-4 inhibitors don't provide any cardiovascular benefit, so not exactly the most optimal option for her at this time. And of the available medications that we're starting in these options, only semaglutide has proven reduction in that MACE endpoint from the cardiovascular outcomes trials. So that would make B the correct answer here. Starting dapagliflozin may be a good option if this patient also had heart failure. However, because we're using it primarily for her type 2 diabetes, that eGFR cutoff for use is currently recommended at 45, so not recommended in this patient at this time. Additionally, C would be incorrect because you wouldn't want to change to another DPP-4 inhibitor as they have limited absolutely no cardiovascular benefit. And then continuing saxagliptin and starting exenatide would be inappropriate. I did not get a chance to discuss this before. However, DPP-4 inhibitors and GLP-1 agonists do act in a similar mechanism of action. However, they are not synergistic. So adding them and using them together often causes increased costs for your patients with limited clinical benefits. So they should not be used together. Additionally, exenatide provides no cardiovascular benefit and should not be used in an eGFR less than 45, which this patient has. And our next patient is a 75-year-old African-American male with HFrEF as well as type 2 diabetes. And based on his eGFR, he has stage 3 CKD. So let's go ahead and read through that case again. I'll discuss the best options. All right. So this patient has both heart failure, reduced ejection fraction, as well as chronic kidney disease as comorbidities to his type 2 diabetes. And this would make initiating an SGLT2 inhibitor the most optimal choice from the ADA algorithm. This makes answer C the most correct option. So for his metformin, we know that it can be continued for use down to an eGFR less than 30. So we wouldn't want to discontinue that at this time as long as he's hemodynamically stable. This patient's 75 and he has chronic kidney disease. So glyburide really hasn't been recommended in the guidelines for quite a while now. And it's especially not recommended in older patients with chronic kidney disease due to the risk for the accumulation of its active metabolite that puts him at risk for hypoglycemia. So that should be one of the first interventions that we make for this patient. This would make C the best answer. Dulaglutide may be an appropriate option if a patient could not tolerate an SGLT2 inhibitor for their HFrEF or CKD. However, in this case, adding dulaglutide would be inappropriate since the patient is also on a DPP4 inhibitor. So you'd have to remove that linagliptin first before adding dulaglutide. So I've heard a lot about concerns for coverage with these medications. In general, most of our commercial payers, as well as Medicare payers, do cover at least one agent with positive cardiovascular outcome data in their class or in their formulary. For those commercial payers, there are manufacturer savings cards available with a quick Google search, and those can be applied to patients' copays. Patient assistance programs are also available on those manufacturer websites, and those can be great for the underinsured, as well as those Medicare patients that are in their Medicare coverage gap, which is unfortunately becoming earlier and earlier. With regard to the Medicaid plans, this is the first year where all the managed Medicaid plans kind of synchronize across the board to have the same formulary. So there are 2 SGLT2 inhibitors and 1 GLP-1 agonist with positive cardiovascular data on the Illinois formulary for 2020. And of course, for any of these plans, if you find that an alternative agent is more appropriate for your patient, you can consider submitting a formulary exception request with the appropriate clinical justification. And the plans are actually pretty receptive in terms of granting those requests or approving those requests. So I've frequently mentioned kind of bringing patients back in a shorter time period, specifically 1 month for some of the GLP-1 agonists. So you may be wondering how to work this into your clinical workflow. I do recommend partnering with your mid-level practitioners. At UIC or UI Health, pharmacists do see patients for chronic disease management, face-to-face, for independent or shared visits with their doctors. We often we are responsible for stopping, starting, and titrating medications, specifically in patients with type 2 diabetes, where their goals are not optimized, or maybe they're not on the correct therapies for their comorbidities. Some qualifications to consider when looking at an appropriate partner are the certified diabetes care and education specialists, or CDCES, formerly the CDE, as well as board certified advanced diabetes management, or BCADM. And those can be good indicators that these practitioners have advanced training. More importantly, looking for someone that's had advanced training in diabetes care as well as cardiometabolic management will allow them to have that practice in implementing these medications and feeling comfortable with using them in clinical practice. All right, and thank you so much. I'm willing to take any questions.
Thank you, Dr. Vandrell. This is Dr. Vogman. I'm going to just ask one question since we're running out of time. I want to make sure that we give Dr. Okwuosa enough time. I know that UTI is a frequent complication or a problem with the SGLT2 inhibitors. How often do you see that? And I just had one of my patients have a great solution for that. She said, I use my bidet and I haven't had a UTI ever since. So just a tip for all the doctors who have patients who are complaining of UTIs.
Well, good clinical or good personal hygiene certainly helps. I think in clinical practice, I've probably seen it in about 10 to 15% of patients. Some patients don't express any genital side effects, while some, have like the worst UTI of their life. Most of them are receptive or are treatable with standard treatment. My personal method for managing those complications, we typically treat the UTI once, and as long as the patient's amenable to continuing therapy, they'll continue. However, if we have to treat a repeat UTI, at that point, we'll consider discontinuing therapy. However, because of the glucosuria and the excretion of basically sugar crystals in the genital area, sometimes the symptoms of a UTI can be misconstrued just from vaginal irritation from those crystals being deposited. So it's really important to do a urine analysis and a culture when those patients present.
Thank you so much for that helpful tip. I want to echo your suggestion that we do a multidisciplinary care for our patients. Here at Rush, we also do multidisciplinary care when we're doing consult rounds. We have a pharmacology team that round with us because it's just gotten so complicated with all the modality of medications that we use in our patients. So I echo your recommendation to have pharmacologists in your team.
Well, thank you. Yes, it seems like we're always having new cardiovascular and renal data to keep up with. And what's fantastic about the ADA guidelines is that they're now a living document. So that data is consistently being integrated into their recommendations.
All right, thank you so much, Dr. Vandrill. We can entertain more questions at the end of Dr. Okwiosa's talk, but I'd like to turn to Dr. Okwiosa at this point. Dr. Okwiosa works with me at the Rush Heart Center for Women. So she is a cardiologist and an associate professor of medicine at Rush. She is giving us a talk entitled Cardio-Oncology, What Have We Learned About Preventing and Predicting Cancer Therapy-Related Cardiotoxicity? She is the director of cardio-oncology here at Rush. She has since spearheaded a number of successful cardio-oncology initiatives, including the biennial Midwest Regional Cardio-Oncology Symposium, geared toward education of healthcare workers involved in the care of the cancer patient. She also founded the triannual Chicago Citywide Cardio-Oncology Rounds, where cardio-oncology cases are presented and discussed by physicians and trainees interested in cardio-oncology. She further organized a monthly CME web content aimed at further educating healthcare workers nationally and internationally. Dr. Okwiosa is the recipient of the Piccolo Gavers Translational Research Grant Award and has published many peer-reviewed research articles, book chapters, editorials, and review articles in the field of cardiology, cardiovascular disease prevention, and cardio-oncology, including the Journal of American College of Cardiology and JAMA Oncology. She sits on the National Cardio-Oncology Committees and writing groups of the American College of Cardiology and the American Heart Association, and has been invited to give presentations and contribute on various topics in cardio-oncology. She's currently the Vice Chair for Cardio-Oncology Council within the AHA and is an assistant editor for the new JCC subsidiary journal, JCC Cardio-Oncology. She has taught me a lot, and I am excited to present Dr. Okwiosa to you. Thank you.
Thank you so much, Dr. Vogtman, and thank you everyone for attending. I know this is kind of getting late, and I will try to make this as interesting and try to hold your attention as much as I possibly can. So my topic, cardio-oncology, what we have learned about preventing and predicting cardiac cancer therapy-related cardiotoxicity. This is not just about chemotherapy, as you will see. There's a whole lot to cardio-oncology than just chemotherapy. And I have no conflicts of interest to disclose. So our objectives for this talk, we will discuss epidemiology of heart disease in cancer patients. We will discuss links and interactions between cardiovascular disease and cancer, cardiotoxicity of various types of chemotherapies, radiation therapy, endocrine therapy, which is used to treat breast and prostate cancer, as well as immunotherapy, which is the wave of the future. And then we will briefly touch on when to refer to cardio-oncology. So we'll start off with epidemiology. So in the United States, when we're talking about deaths due to heart disease and cancer, we can see that in the beginning, back down to the 1950s, heart disease was the #1 killer in the United States, and cancer was way down here, probably due to we weren't diagnosing cancer as much. But in any case, the heart disease risk and risk of death from heart disease has gone up over the years, and we've made so much progress that the risk of heart disease has come down. Risk of cancer and death due to cancer has increased over the years. And in fact, when we look to more recent times, we can see that we're looking at deaths due to heart disease in men and death due to cancer in men. And we can see that death due to heart disease going down to this year, 2020, that death due to heart disease has come down significantly. We've made a lot of progress. For cancer, there has been some progress, but it's a little bit more level compared to heart disease. And this is the same case in women as well. So the death due to heart disease in women we've made a lot of progress. For cancer, it's again come down, but it's level. And it's actually projected based on such data that by the year 2026, cancer would have surpassed heart disease as the #1 cause of mortality in the United States. And when we're talking about cancer survivors, we've made a lot of progress with respect to therapy, right? So chemotherapy, radiation therapy, and all the other types of therapy, especially immunotherapy, so much progress that now we're having more cancer survivors. So as of 2019, we had some close to 17 million cancer survivors in the United States. And it is projected that by the year 2030, we're going to have closer to 20 million cancer survivors, and actually more than that. And as cancer patients are living longer, heart disease is becoming a major problem in this population. So here on the y-axis, we're looking at reduced cardiac reserve and increasing risk of heart failure. And on the x-axis, we're looking at increasing age. So as people age, that kind of makes sense in a healthy patient, that the cardiac reserve will reduce. They would have higher risk of stiffer hearts and heart failure from diastolic dysfunction and reduced LV compliance. But look at those that have heart disease risk factors. You can see how heart disease risk factors increases that risk of heart failure, increases the risk of reduced cardiac reserve, and that makes sense. But look at the cancer survivor. The cancer survivor is actually worse and has reduced cardiac reserve more so compared to the patient who has cardiovascular risk factors. And in fact, in this study by Armstrong and his team, they looked at cancer survivors in the red lines and their siblings in the yellow lines. And they found that the incidence of new malignancy with time is higher in the cancer survivor. And that kind of makes sense. Cancer survivor receives treatments, and the treatments actually predispose them to newer malignancies. And when we talk about hearing problems, that's worse in the cancer survivor, renal problems, worse, respiratory problems, visual problems, and these all make sense. Look at the patient with heart disease. You can see that that patient with heart disease has higher risk of, that patient with cancer has higher risk of heart disease compared to their sibling who's never ever had any cancer. And in this study, they looked at patients with lymphoma, lung cancer, breast cancer, GI malignancies, different kinds of malignancies. And they basically were looking at cardiovascular mortality in this population of young patients aged 15 to 39 years. And they found that there was, particularly for lymphoma and all the other cancers, but it was very noticeable for lymphoma, that the risk of the standardized mortality ratio and the absolute excess risk related to cardiovascular disease for mortality was very high in the lymphoma patients. You can see them here, whether you're talking about Hodgkin or non-Hodgkin lymphoma. And it didn't matter their age group. That was the case for people aged closer to 15 years and those aged closer to 40 years. It didn't matter what year the patients were diagnosed with cancer. So in other words, treatments are getting better. We know that as the decades are going by, but the risk is still high even with newer treatments and treatment modalities. It didn't matter the length of follow-ups too. We were still seeing these increased standardized mortality ratio and absolute excess risk in this population. And when we look at the links between cancer and cardiovascular disease, we can see, and I think this is intuitive to most people, increased risk of smoking. When people smoke, they're obese, they don't eat a proper diet, they have physical inactivity, that increases the risk of cancer. This also increases the risk of cardiovascular disease as well. So here you have somebody who has all these risk factors, who has cardiovascular disease at baseline, then because of these same risk factors, they develop cancer. And then they receive either of these cancer therapies, anywhere ranging from chemotherapy to radiation to targeted therapy. Well, then because they have cancer and they have heart disease issues, people are less likely to offer them different kinds of cancer therapies, particularly because of the heart disease that they have. And also, they're more likely to develop cardiotoxicity as a result of their baseline cardiovascular disease. They're most likely to develop cardiotoxicity from their cancer therapies. And then you look at the fact that these people already have worsened factors from their baseline disease, and they're also already getting cardiotoxic cancer therapy. And you can imagine what happens, right? So they're cancer survivors and they have higher long-term risk. Or the sad part of it also is that some of them may die as a result of their cardiovascular disease while they're receiving cancer therapy. Heart disease patients are more likely to have a higher risk of cancer compared to the general population, and vice versa. So we're looking at the links between heart disease and cancer. So this particular agent called canakinumab, right, is a monoclonal antibody that targets interleukin-1 beta, which is an inflammatory marker. And what canakinumab does is that it reduces interleukin-1 beta, and studies that have looked at canakinumab and risk of looking at cardiovascular endpoints like MI, stroke, and cardiovascular death find less risk dependent on the dose. So here we're looking at 50 milligrams of canakinumab, 150 milligrams, 300 milligrams. And we're looking at these endpoints like I talked about. And you can see that those in the red line have less risk of these primary cardiovascular endpoints compared to the placebo. And so with 50 milligrams, you have reduced less risk that is getting close to being statistically significant, but we see a higher level of significance at higher doses of 150 and then 300 milligrams of canakinumab. And when we look at lung cancer, the story is the same. So for patients that are receiving canakinumab, especially for those that receive 300 milligrams of canakinumab, we see less risk of lung cancer and deaths due to lung cancer as a result of this particular agent. So you have one particular agent that is targeting a particular immunomodulatory factor, which then reduces both heart disease and lung cancer. So that suggests that there is a link there. And then when we look at CHIP, so clonal hematopoiesis of indeterminate potential, which is really a clone of some hematopoietic cells that we see in people who are older, who have no baseline risk of cancer. These patients have higher risk when they have CHIP. They have higher risk of coronary heart disease, as you can see here, and also higher risk of early onset myocardial infarction as well. These people also, incidentally, are at higher risk for having hematologic malignancies as well. So again, something that could be a potential link between the two disease processes. And in this more recent study that was just published this year in Nature Medicine, they looked at, it was more like a translational research, and they looked at mouse models, breast cancer mouse models, and they performed experiments where they occluded the coronary arteries to create myocardial infarction in these mouse models. And then they also did sham procedures in these mouse models. And they found that the mouse models that developed myocardial infarction, again, these are breast cancer mouse models. So those of them that developed myocardial infarction had higher tumor volume compared to eventually, so higher risk of tumor recurrence and higher risk of metastases from breast cancer in those that had MI compared to those that did not have MI. And this particular group of authors also conducted the same sort of study in human beings. Of course, they did not create MI, but what they found was that for those of them that had breast cancer, that had MI, those that had MI had higher risk of breast cancer recurrence and higher risk of breast cancer specific mortality. And this is the p-value for it. You can see how statistically significant it is. So again, these all make the case for a link between cancer and cardiovascular disease. So what sorts of cancer therapies do we think about when we're thinking about cardiovascular toxicities? So we're looking at systemic effects of various chemotherapeutic agents. You have cardiomyopathy and heart failure. This is something I think most people know. Everybody thinks about doxorubicins and anthracyclines in overall. But we also have other agents that cause cardiomyopathy and heart failure. We have risk of ischemia with certain agents, thrombosis with certain agents, risk of hypertension, hypotension, arrhythmias, and also risk of QT prolongation and pericardial disease. So you can see that there is a whole slew of cardiovascular diseases that can be induced by chemotherapeutic agents overall. And if we talk about anthracyclines, we talk about doxorubicin, which inserts into the myocardial cell and basically attacks the DNA and the mitochondria, generates reactive oxygen species, inhibits topoisomerase 2, intercalates with iron to cause more cardiovascular damage, impaired calcium handling, which then leads to myocardial cell death and fibrosis. And this is an example. So you can see the striated muscles of myocardial cells that look normal, And when they receive anthracycline, this is what happens. You can see fatty infiltrates and myocardial fibrosis in different areas. And this is what happens and leads to heart failure in these patients. And you can imagine that with fibrosis, when these patients develop heart failure, reversing that heart failure can be difficult, especially if you've let that fibrosis develop. And so I'm here to also to just mention very briefly other agents that can cause cardiotoxicity in cancer patients, that can cause cardiomyopathy and heart failure in cancer patients. So apart from the anthracyclines, we also have trastuzumab, anti-HER2 agents that are used for breast cancer, bevacizumab used for gynecologic malignancies, and so also protease inhibitors that are used in multiple myeloma. There are also other agents like the tyrosine kinase inhibitors that are used for various types of malignancies, many different types, including renal cell cancer and so on. So there are a whole bunch of other agents that we need to be aware of that can cause cardiomyopathy and heart failure. And cardiomyopathy relating to anthracyclines particularly can be acute, usually within the first week, which is usually reversible. Subacute within the first year after treatment, that's where you have mostly at least 95% of patients that develop cardiotoxicity will do so within the first year. And then you have chronic long-term cardiotoxicity, which is basically a lifetime risk in these patients. So that's important to know, particularly for monitoring in patients that have received high-dose anthracyclines. And when anthracyclines are combined with drugs such as trastuzumab, for example, in breast cancer, you have higher risk of cardiotoxicity. In this particular study, they were looking at risk of heart failure with time, and you found that that risk was higher when the patients used anthracycline, when they were receiving anthracycline and trastuzumab. And so we should, when these patients develop heart failure, think about the fact that it's important to diagnose them early, because again, I showed you the fibrosis that can develop when patients receive anthracyclines. When that fibrosis develops, it's really hard and almost impossible to reverse their cardiomyopathy. And in fact, studies have shown this. And so it's important that we test based on pathophysiology. If you have the exposure here, when you test with lab data, if you're able to test their lab data from time to time to see if they have an elevation in troponin or BNP, you would be detecting injury that's happening early in the phase of cardiotoxicity in these patients. The other thing to use later on, as you start to get cell death, you have abnormal strain imaging. So that's one thing that we do use in monitoring these patients as well, in addition to the cardiac biomarkers, as I said earlier. By the time you have a drop in ejection fraction, it's kind of getting late because a lot of the injuries have already occurred in that process. And so monitoring based on cardiac biomarkers and strain echo is usually more prognostic in these patients compared with LV ejection fraction, which happens later on. And one way to prevent doxorubicin or anthracycline-induced cardiotoxicity is a drug called dexrazoxane, which is Zenecard. Iron chelator, I did show you that that iron is one of the ways that doxorubicin can induce cardiotoxicity. And so using dexrazoxane as an iron chelator, we can use it to prevent doxorubicin-induced cardiotoxicity. And it's really used in kids. Basically, all these kids that develop lymphoma, that develop leukemia, we do use dexrazoxane to prevent cardiotoxicity in those patients. And we can see here, for example, that the red bars represent doxorubicin and the pink bars represent dexrazoxane plus doxorubicin. And in this study, they looked at troponin T over time with use of these agents, depending on the group that you belong to. And they found that troponin T levels increased with time in patients that received doxorubicin alone versus those that received dexrazoxane plus doxorubicin. You can see how flat their bars are. And actually, you would have lower troponins in the population that received the dexrazoxane plus doxorubicin. Other things that we do worry about with cancer patients include hypertension that can develop from anti-cancer therapies. And particularly the agents that can cause hypertension include bevacizumab. Again, that's used for gynecologic malignancies. Drugs like everolimus and temsirolimus, drugs like the tyrosine kinase inhibitors, which are again used for various malignancies. And there are ways to manage hypertension and specific drugs to be used for managing hypertension with a lot of these agents. When we look at the VSP inhibitors, which are the VEGF inhibitors, that they are supposed to be responsible for things like cell proliferation, survival, vascular permeability, and cell migration. And so when we use the VEGF inhibitors, like the tyrosine kinase inhibitors, to prevent all of these, this is what we get. So the hypertension, the cardiomyopathy, arterial thrombosis, QT prolongation, and edema. So these are side effects of these tyrosine kinase inhibitors, which are again used for various types of malignancies. And in fact, the hypertension that develops from these agents is a marker of cardiotoxicity. In this study, they looked at patients that hypertension is a marker of response to therapy. In this study, they looked at those that had hypertension with therapy, with the tyrosine kinase inhibitors or the VEGF inhibitors, and those that did not have hypertension with these agents. And you can see that survival was much better for those that had hypertension. So it really is a marker of response to therapy. So it's a good thing when they develop hypertension. Ironically, it is a good thing. However, those that did not get treated for their hypertension did not do as well as those in the red lines that got treated for their hypertension. So it's important to monitor their hypertension because their blood pressures could be so bad that they end up developing strokes. So it's important to monitor their blood pressures and actually institute certain therapies. ACE inhibitors tend to work very well for this population, as well as the dihydropyridine calcium channel blockers. Other things that we can see are myocardial infarction and ischemia, which you can see with drugs like the anti-metabolites like capecitabine and 5-fluorouracil or 5-FU. They can cause myocardial infarction secondary to coronary vasospasms. And these patients, when they're receiving these drugs, have to be informed that if they ever develop chest pains at home, they need to head straight to the emergency room because they could be developing coronary vasospasm that actually does lead to myocardial infarction and ventricular arrhythmias and sudden deaths in these patients. Drugs like nilotinib and ponatinib, which are tyrosine kinase inhibitors, can also lead to MIs, and bevacizumab, again, is another agent that can lead to MIs. Thromboembolism that you can see with drugs like cisplatin, angiogenesis inhibitors, bevacizumab, again, the tyrosine kinase inhibitors. And so low threshold to start these patients or to initiate aspirin therapy. And if they have history of DVT, you want to have a lower threshold in future to institute anticoagulation, even if they don't have active DVT at that time. QT prolonging medications, arsenic trioxide is an important one. We do institute that medication in the hospital because you want to closely monitor their EKGs for QT prolongation and other tyrosine kinase inhibitors as well. Monitoring is important when these patients are a risk for QT prolongation and making decisions on therapies for managing their QT prolongation. And then we have drugs like ibrutinib that can increase the risk of AFib. That risk of AFib is usually higher within the first year, highest within the first year. Even for those that do not have baseline atrial fibrillation, up to 10% of them, 5 to 10% of them within the first year would develop AFib on ibrutinib. They're also at risk for ventricular arrhythmias as well. And for those that have AFib at baseline, that risk of developing chronic AFib is higher in this population. And, this is just a schematic that just shows different things that can develop with these cancer therapeutic agents and how best to manage them. We will touch briefly on radiation therapy. So when patients receive radiation, they can get oxidative stress to coronary arteries and basically the myocardium, a myocardial cell, and different vessels. They develop oxidative stress, they get activation of NF-kappa beta and recruitment of inflammatory cytokines that lead to foam cell recruitment and foam cell formation, which then leads to coronary disease. And in fact, coronary artery disease is one of the major issues that we see with patients that receive chest radiation, especially for those that received mantle radiations in the 1970s, 1980s, and early 1990s. Up to 85% of them can develop coronary disease, especially involving the LAD and the RCA and the left main. So that's important to remember. We know when it's coronary disease that's induced by radiation because it's usually a napkin ring tubular specific area, discrete area of coronary blockage that we see. They can also develop valvular heart disease and conduction system abnormalities, pericardial disease, and cardiomyopathy. And in this study, we always used to think that radiation-induced coronary disease came 20 years later. Radiation-induced MI and ischemia came 20 years later. But in this study by Darby and her team, they show that even in the early years, 0 to 4 years after radiation therapy, patients are still at risk for having myocardial infarction, and then up to 20 years and beyond. I want to make sure that I touch on autonomic dysfunction, which can develop in patients who receive radiation therapy. This risk of autonomic dysfunction with radiation therapy increases with time. So as the patient's age, the risk of autonomic dysfunction after receiving radiation therapy is higher. So that's very important to note, because you have these patients that received radiation therapy years ago, 20 years ago, and now they're presenting with problems with sinus tachycardia, fluctuating blood pressures, and symptoms that mimic POTS syndrome. It's important to think about the fact that they received radiation therapy and at least have an explanation for the reason why they're having autonomic dysfunction, which again worsens with time, unfortunately. We do these days have neuroradiation therapy techniques that we can use in modulating these risks of radiation-induced heart disease. Things like intensity modulated radiotherapy, deep inspiratory breath holding techniques, where you can have somebody doing a radiation, you have them take a deep breath when you're imaging it, when you're radiating a certain area. When they take a deep breath, it may shift the heart out of the way, and then you can irradiate a certain area. Prone positioning, especially for breast cancer patients, when they're prone, you can image them, you can radiate them from the side so that you can avoid the heart that way. 3D conformal radiation therapy, and of course, proton therapy, which we hear about on ads. How about other agents such as endocrine therapy or hormonal therapy for breast and prostate cancer? The SERMs, drugs like tamoxifen, which we all know about, and the aromatase inhibitors like letrozole and anastrozole and exemestane that are used for breast cancer. Even these can have cardiovascular consequences. And very briefly, tamoxifen studies have compared tamoxifen with the aromatase inhibitors, and I found that there's higher risk of cardiovascular events with use of aromatase inhibitors and less so with use of tamoxifen. On the other hand, there's higher risk of venous thromboembolic events with use of tamoxifen and less so with use of aromatase inhibitors. So these are things to think about, discuss with the patient whether they will be good candidates definitely for statin therapy plus or minus aspirin therapy to prevent some of these effects. How about anti-androgens for prostate cancer? Those also do come with their own risks. They do increase risks of things like metabolic syndrome, insulin resistance, fat mass, diabetes risk, and so on. And as a result, they do increase risk of cardiovascular events. And so in this study from JAMA, for those that do not have baseline comorbidities, the ADTs or androgen deprivation therapies that we use for prostate cancer have less risks. However, that risk starts to go up when they have cardiovascular risk factors, and definitely the risk is highest when they have baseline cardiovascular disease. How about immunotherapies? I cannot finish this talk without mentioning immunotherapies, which has changed cancer therapy significantly. So it used to be that, in the olden days, 5 years, 10 years ago, when patients have had things like melanoma, multiple melanoma, and certain types of cancer, the renal cell cancer and so on, the mortality risk was higher. And small cell lung cancer is another example. Mortality risks were higher. However, with advent of immunotherapies, these risks are much improved. These patients are living longer, 5 years, 10 years, and actually we are getting cures now. Immunotherapies are actually curing diseases like multiple myeloma, even metastatic multiple myeloma, which is, metastatic melanoma, malignant melanoma of the skin, which is amazing because we all know how deadly malignant melanoma can be. And so we have targeted therapies that can target different tissues and different cells and different receptors. And this is where the concept of immunotherapy, immune checkpoint inhibitors, came into being. There are many of them that have been developed now that are used to treat different kinds of cancers to improve survival. And the general idea behind them is that you have the tumor cell that infiltrates the human cells. The T cells ordinarily are supposed to attack foreign bodies or foreign cells, but the tumor cells are so smart that the tumor cells come in and actually attach to these PD and PD-L1 receptors and other receptors within the T cell and basically incapacitates the T cell. So the T cell is unable to attack the tumor cell. And this is the wisdom and the smartness of immunotherapies, and the intelligence is that the immunotherapies then are supposed to be competitive inhibitors. And what they do is they come in and they competitively attach to the T cell and free up the particular receptor that then attacks the tumor cell. And so the immunotherapies are very effective for this reason in killing the cancer cell, because they let our own bodies attack the cancer cells. And there are very many of them now that you can see that are on the market used to treat different kinds of cancers, including, again, melanoma and small cell and non-small cell lung cancer and other types of malignancies. The problem is because our own cells, our own immune cells are attacking the tumor cells, our own immune cells can also attack our own cells and create symptoms that are similar to autoimmune diseases. So as you can see here in this schematic, you can have thyroiditis and hypothyroidism, pneumonitis, hepatitis, different things, different parts of the body that can be inflamed because of the immune reaction that's created. And particularly from a cardiovascular standpoint, you can get a myocarditis. Now, the myocarditis associated with immune checkpoint inhibitors is not very common. That's important to state. Only about 1% or less of patients who develop a myocarditis. However, when they do develop a myocarditis, there's up to 50% mortality. So 1 in 2 people that develop a myocarditis can die from it. And so it's important to recognize it early, which is the reason why the monitoring is important, so that these patients can be treated very early. It's a very prominent process, and so they need to be treated like giant cell myocarditis, basically, with high-dose steroids and immune modulatory drugs that should be instituted early enough before the patients die from it. And this is just touching on different ways that we can diagnose the myocarditis from this. Most important thing is really monitoring them with cardiac markers, troponins, BNPs, EKGs, just to make sure that we're not missing anything in these patients. And so I just hope I've convinced you that there are very many different parts and parcels of cardio-oncology. And when we're thinking about cardio-oncology, we think about the patients prior to treatment. If they have risk factors that could predispose them to any of these diseases, then it makes sense to refer them to be monitored while they're receiving treatment. While they're getting treatment, if they do develop cardiovascular complications, it's important to refer them early enough before the problems become so cardiotoxic that they can't even get their chemotherapy, or worse still, that they die from it. And then after treatment, especially if they've received high-dose anthracyclines, high-dose radiation, or if they developed cardiovascular complications during treatment, then they should definitely be referred for further management. And I always say that the aim of cardio-oncology is not to prevent cancer patients with cardiovascular disease and risk factors from receiving necessary life-saving cancer therapy, but to prevent and or treat cardiac disease as best as possible alongside their cancer therapy and care. And again, it's usually a multidisciplinary approach, a team approach involving the hematology oncologist. Of course, the cancer patient and their family have to be involved, the cardio-oncologist and the general cardiologist that's interested in seeing these patients, and a lot of research, because there's still a lot that we need to understand regarding interactions between cancer and the heart. And so there's a lot of research and a lot of questions that we need to focus on for the future of these patients to make things better. Thank you so much for the opportunity.
Thank you so much, Dr. Okuyosa. Actually, there are no questions from the group, so you answered all the questions that I had, which was when do we refer our patients to a cardio-oncologist? And you said before they even get treatment. And hopefully there are enough cardio-oncologists for all these patients that we will be continuing to have. All right. Well, thank you so much for all the speakers. And if there are no other sessions or questions, please register for the next meetings that we're going to have. We are going to send you some emails in the next day or two to obtain credits for this.